So, good morning everyone. Now, today we are going to discuss a bit on the cystic kidney diseases. Okay. So, the other organs like heart, like brain, they do not have a common seen cystic diseases, but the liver, the lung, the spleen and ovary, kidney are also having multiple cystic diseases. Now, these diseases are different than the tumor of kidney or the parenchymal diseases of kidney. So, the first thing is what you are supposed to learn in that is what is the classification of these cystic kidney diseases. The second thing is what is the inheritance pattern and the genetics behind these kidney diseases, the common etiopathogenesis related to kidney diseases, laboratory finding, urinary finding, distinguishing feature and the complications of cystic kidney diseases. When similar to the other organ, the kidney is going to develop, this is the urogenital tract, and during the development there are abnormalities. Okay. So, when there are abnormalities, they can lead to the abnormalities which are congenital in nature in the kidney and urogenital tract. So, commonly it is called as a Charcot or Kakut, and the incidence is 3 to 5 in 1000 live births. So, it is not so infrequent, every 3rd to 5th individual among the 200 will have a disease, and these malformations can be detected by ultrasound when there is a developing fetus in womb in 25 to 30% of the cases. Then it is also responsible for half of the pediatric renal diseases, and therefore, it is important for all of you to understand what are the common diseases. In the undergraduate syllabus, it is important to you people aware of what we are seeing frequently. Okay. So, because of that, this topic is there for undergrad learning. Defect in the terminal maturation cystic diseases, then if there is a defect like that, then it is the Mendelian or the single gene disorder. Now, coming to the congenital anomaly of kidney urinary tract is can be the isolated or the non-syndromic one, or it can be manifest in multiple organs, then it becomes syndromic. So, when it is like that, the non-syndromic are multifactorial with the polygenic contribution. Various genes like they are mentioned here are HNF1B, PAX2, UPK3A, AGTR2. So, when that type of a scenario is there, these are the genes identified and they are seen involved. The developmental field defects are also a unknown etiology, means that complete field where the earlier the cloacal part which is there and which is being separated in the urogenital system and the lower part of the developing intestine of the colonic area. Fair enough. So, that is also unknown in the etiology. So, they are isolated and non-syndromic in nature, and genetic testing is not so required, but there are certain ones which are syndromic, which can be either of Mendelian inheritance or they can be having a chromosomal abnormality such as Down, Turner, Patau and many other. Now, when we are seeing here the developmental cascade So, from the mesonephric and metanephric mesenchyme and the duct system, then there is a development of ureteric buds and the development of nephron precursors. So, they are developing and they will take a shape of a normal kidney with the fetal lobulations. When the size is small with all structures normally located on microscopy in the kidney, then it becomes hypoplastic. But when they are become more disorganized and taking a form of cyst, it becomes cystic and dysplastic kidney. In addition to that, when the mesenchyme is not taking much part, but the cysts are prevailing, that is multicystic dysplastic kidney. The cyst lesser than the kidney is smaller than the hypoplastic and very small aplastic or tiny dysplastic remnant can also be seen, which is not normally identified in the fetal ultrasound and on the fetal autopsy as a identifiable kidney. Then that can be the small dysplastic remnant of kidney or a tiny aplastic kidney or complete renal agenesis, which can be the unilateral or if bilateral not compatible with life. So, this is a complete spectrum of congenital abnormality of kidney and urinary tract. Among them, what we are going to cover today are these two entities in detail. Fair enough? Now, as I told you earlier, in the Charcot, that is the congenital anomaly of kidney and urinary tract, lot of genes identified in the monogenic or Mendelian inheritance as a single gene disorder. Okay. So, in that multicystic dysplastic kidneys, kidney dysplasia, kidney mesangiolipodosis, renal dysplasia, calcium malformation, agenesis dysplasia and many other. So, if we go and see that multiple either are having a renal agenesis or they are having a dysplasia and these many genes are involved. तो इन वन गो जेनेटिक टेस्टिंग करनी है तो क्या कर सकते हैं हम, एक इसकी लाइब्रेरी कंस्ट्रक्ट करेंगे और लाइब्रेरी कंस्ट्रक्ट करने के बाद इनके बारे में आइडिया ले सकते हैं कि कौन सा जेनेटिक एबनॉर्मेलिटी प्रिवेल कर रहा है इन द कंजेनाइटल एनोमली ऑफ किडनी एंड यूरिनरी ट्रैक्ट. So, there are type 1, type 2, type 3 and type 4. This is a very old and very famous Porter classification. ये आपको पता होना चाहिए. Okay, तो note it down, what is Porter classification of normal and abnormal development of kidney. It is published and this is type 1 called as a enlargement of cortical and medullary collecting duct of the both kidney, usually cause death soon after birth. Type 2 is amply of collecting duct are profoundly altered and incapable of producing functioning nephron, death result if bilateral. Cysts are located in collecting duct and segment of nephron and almost always bilateral and principally affect adult. So, this is type 3 kidney which is seen mainly in the adult. Fair enough? And type 4 they are present at birth, produced during distension of terminal portion of S stage nephron because of urethral obstruction. So, once urethra is being obstructed, then kidney is becoming cystically dilated. Fair enough? So, these are the 4 classification schemes and you are supposed to know this Porter classification for kidney and urinary tract. The classification of renal cystic disease, this is today's topic. Okay. तो इसको 2 मेजर पार्ट में हमको डिवाइड करना है. वन इज द पीडियाट्रिक ऑनसेट एंड अनदर इज अडल्ट ऑनसेट. सो बेस्ड ऑन दैट two famous names which are very popular are called as autosomal recessive polycystic kidney disease is pediatric onset. ये हमेशा याद रखना है. Even in the fetus we can be able to identify. I had a experience of 6 such cases at Nizam Institute and one case here. We had a diagnosis of autosomal recessive polycystic kidney disease and autosomal dominant. It is so big, this size, and that is autosomal dominant in nature, and these kidneys, when it is recessive or whether it is adult, they are called as a large kidneys. Large kidney for the size of that age of fetus or child. Fair enough. They are cortical cyst. They are having a PKHD gene which codes for fibrocystin protein. While in the adult, these large cysts are seen throughout, that is in the cortex as well as in medulla. PKD1, PKD2 genes encode for polycystin. So, here it is fibrocystin and here in the adult it is polycystin. Okay. Now, the second entity in the pediatric age group is nephrophthisis. In comparison to ARPKD, it is having a small cyst for that given age, a small size of kidney. Then corticus and medullary, both areas cysts are supposed to be seen. NPHP gene encode for nephrostatin protein. Then the third entity which can be seen in the pediatric age group is multicystic renal dysplasia. Here the kidney is of variable size, cysts are also variable size, heterogeneous tissue, the cartilage, calcification, bone can also be seen in this, and mesenchymal collar can be seen around the tubules. No specific gene defect is identified in this subset. तो जब आप ये प्रीवियसली पैनल दिया है ये करेंगे तो आपको जेनेटिक डिफेक्ट नहीं आइडेंटिफाई होगा. ओके. नाउ इन द एडल्ट, इन एडिशन टू ऑटोसोमल dominant polycystic kidney disease, medullary sponge kidney is another common entity where the normal size kidney can be seen, medullary cyst can be seen, no gene defect identified. Medullary cystic disease are small kidney, corticomedullary cyst, MCKD gene mutations are seen in the medullary cystic disease. Now, we are going one by one to these common 6 to 7 entities which are cystic kidney disease, and some cases of my collection also I will like to share with you. So, your learning will be little better. Okay. So, autosomal recessive polycystic kidney is, name speak itself is, it is autosomal recessive inheritance in Mendelian pattern, that is 25% recurrence risk from the parent to sibling, offspring. Kidneys are affected bilaterally, present with oligohydramnias due to poor renal function and failure to form significant amount of fetal urine. Oligohydramnias lead to pulmonary hypoplasia, insufficient lung capacity to survive because of the pulmonary hypoplasia. Autosomal recessive polycystic kidney result from the mutation in PKHD1 gene which decodes the fibrocystin, which is membrane associated receptor like protein. So, this fibrocystin, which is a protein, is involved in ciliary signaling cascade and it regulates proliferation and differentiation of renal and biliary tract epithelium. Abnormalities lead to dilatation of renal collecting duct and it becomes cystic in nature. Liver also show duct plate malformation, where there is a increased number of dilated bile duct in expanded fibrous connective tissue called as congenital hepatic fibrosis. So, one such case we have seen here in the syndromic type of a nature, where multiple organs are being involved in the autosomal recessive polycystic kidney disease. Now, when we are having such type of a cases, here what we are seeing here is like a fetal lobulation, but they are more exaggerated or more prominent in nature. And when we see the parenchymal morphology of the kidney, here we are seeing the multiple layer of developing glomeruli. So, we can have a Z shape, C shape, and then they are taking a developmental phase. So, these kidney are markedly enlarged for the given gestational age or the child age. Then they are symmetrically enlarged. These are the both kidneys which are symmetrically enlarged. These cysts are quite small and uniform, perhaps 1 to 2 mm of average size. Microscopically, in the late third trimester, these cysts are taking a elongation in the shape and they are seen radially arranged. So, in microscopy, we can be able to identify what type of a cyst are there. The few remaining glomeruli are not involved in the cyst and intervening parenchyma is not increased. The second trimester cyst may not be very well developed. So, in comparison to this developing parenchyma, what will happen in this disease condition? Here we are able to see the autosomal recessive polycystic kidney disease. So, what we are seeing, this is the area of cortex and this is the area of medulla. So, if you see where the cysts are primarily located, they are located in the cortex. And what type of a shape they are having? They are having radial arrangement like this. You can see it here, they are radially arranged, okay, and they are having a fusiform shape like that. So, these are very classical in nature and we can be able to identify nicely. Now, in comparison to this kidney, if we are seeing this liver, what will happen here? Here we are be able to see duct plate malformation. So, what are the duct plate malformation? Here, if we see the liver parenchyma, there are portal tracts and there is a central vessel. So, here those structure formation is ill developed, fibrosis is the terminal form occurring in the liver. Okay. So, these are the conditions we can see. Now, we will go to the second entity. Here multicystic renal dysplasias are there. These are sporadic inheritance pattern, most common form of inherited cystic renal diseases. It result from abnormal differentiation of metanephric parenchyma during embryonic development of the kidney. It can be unilateral, so it affect person can survive. So, if both the kidneys are not involved, person can survive and have a normal life, because we know in principle even for survival one kidney transplantation is sufficient. Okay. So, if one kidney is normal by birth, they can survive. With absence of one functional kidney from birth, other kidney undergoes compensatory hyperplasia, because the other kidney has to take over the function of bad kidney. Fair enough. Many reaches size similar to the combined weight of two kidney, that is the 4 to 500 grams. The normal weight of kidney is around 225 to 250 grams, like that. Okay. The multicystic renal dysplasia, they are coming in the type 2 Porter's classification category, which I told you earlier. They are the two main subgroups. The affected kidney is large, then the term type 2A. If the affected kidney is quite small, that is the hypodysplasia or type 2B. So, the Porter classification type 2 is having A and B, which is having a large or a small as A or B respectively. The different combination are possible. So, only one kidney or part of one kidney can be affected and be either large or small, okay, because they can be either portal type 1 or portal type 2. Is it clear? So, because of those combinatorial nature, they can present in a multiple manner, and we should be aware of that fact while doing the ultrasound in the developing fetus or while doing the fetal autopsy. Both affected kidneys can be large or both can be small, or one can be large or one can be small. So, these all are the different permutation combination. It is quite common of asymmetry to be present. Grossly, cysts are of variable size and from 1 mm to 1 centimeter is size and filled with clear fluid. So, here what we are able to see, it is just like a horseshoe kidney, where one arm is quite small and another arm is comparatively larger. Okay. So, here one kidney is small and another kidney is larger, and both the kidneys are cystic in nature. This is another where both cystic kidneys are similar in size. So, these permutations and combinations what we discussed in the theory slide before are supposed to be present in these photographs. Microscopically, what we are able to see when we process these kidney specimens, there are few recognizable glomeruli and tubule, and remaining glomeruli are not affected by the cystic change. So, they may be potentially functional in nature. Hallmark of renal dysplasia is present, and primitive ducts are lined by cuboidal to columnar epithelium and surrounded by collagenous stroma. This increased stroma may contain a small island of cartilage. Liver will not show congenital hepatic fibrosis as it is seen earlier in which disease? Yes, autosomal recessive, very good, polycystic kidney disease, good. So, the next entity in this line is multicystic renal dysplasia. So, as name connote, the multiple cysts are there in this entity, and this is often the only finding, but it may be seen in the combination of other abnormalities such as in Meckel-Gruber syndrome, in which there is a recurrent risk of defined, and this disease is bilateral and probably associated with oligohydramnias. Pulmonary hypoplasia is the rate limiting step of survival. So, here these are the cysts, and this is a undifferentiated type of a mesenchyme. Here the cartilaginous tissue is there, and this is a mesenchymal collar can be seen around these tubules. So, here this is a thoracic area where we can see the very small lung. Here the normal lung, this is a heart and this is a liver. So, we can see a small pulmonary tissue called as a pulmonary hypoplasia. Here we can be able to see these are the tubular structures. So, ductotubular structures are seen in this lung specimen in the multicystic dysplasia. Now, this is one case. Here there is a third degree consanguinity, first trimester abortion is there, and 28 weeks the fetus was terminated, and the ultrasound finding is right side kidney has a multiple cyst, left side having a hydronephrosis, polyhydramnias. So, on the ultrasound then we had a fetus, and then we are having these are the fetal internal organs of the abdomen, and we can see clearly this is a cystic kidney. Now, we can see here this is a one kidney, another kidney, and we can be able to see that there are fetal lobulation which is in the form of cyst. This is a collapsed cyst, you can be able to identify, and it has a low recurrence risk of 2 to 3%. Another is a multicystic dysplastic kidney, it is a second degree consanguinity. There is a first trimester abortion to the couple, and the fetus which is submitted for fetal analysis of autopsy 23 weeks in nature. Ultrasound what we have seen bilateral kidney will multiple cyst of variable size, severe IUGR oligohydramnias, normal uterine Doppler, cardiomegaly and tricuspid regurgitation. So, what we are able to see here is the normal foot, and we can be able to see the internal organs, and then these are the cysts. We can see these cysts, they are quite collapsed cystic areas in the both kidneys. On the cut open, the renal parenchymal shape is not at all maintained, it is totally damaged. So, that is not compatible with the life of fetus. So, there are growth restrictions with normal uteroplacental circulation, multicystic dysplastic kidney can be seen, dysmorphism can be seen, cardiac involvement, tricuspid stenosis can be seen. They can also have the syndromic etiology, normal fetal chromosomes can be seen, parental consanguinity, that is a high risk up to the 25%, that is coming toward the relative risk of autosomal recessive type of a inheritance pattern. Is it clear? Okay. So, now the fetal and pediatric kidney diseases which are common we covered significantly, and the second part is autosomal dominant polycystic kidney disease. Autosomal dominant pattern is recurrent risk in affected family, that is the 50%. It is one of the most common genetic diseases with incidence of 1:400 to 1:1000 persons. Diseases rarely manifest itself before the middle age. So, these are the things what we are able to see. In comparison to the normal kidney, they are very huge kidney. They are like size of we can say 15 to 20 centimeter in length and very big in size. Normally, the kidney is having a 10 into 5 into 2.5. So, you have to remember that figure. In comparison to that, these are quite large. You can see the complete scale of a foot size. Okay. Now, autosomal dominant polycystic kidney, it begins in the middle age to older adult and cause progressive renal failure as a cyst become larger and functioning renal parenchyma is smaller in volume. This form of cystic disease is rarely manifest prenatally or in children. ADPKD shows defect in PKD1 gene, more common. PKD1 encodes for polycystin and PKD2 encodes for polycystin 2. The polycystin function in calcium channel and disruption of normal intracellular homeostasis may underlie cyst formation. There are many alleles explaining variation in onset and severity of autosomal dominant polycystic kidney disease. So, PKD1 and PKD2 are the common genes which are important for understanding that they are responsible for the defect which triggers in the adult life, and the people which are middle age or old age manifest with this. So, its trigger is not early part of the development, trigger is in the middle age. That is why these diseases manifest in the adulthood. Okay. ADPKD are grossly very large size, perhaps up to 2 to 3 kg. Affected kidney are just a mass of large fluid filled cyst, often hemorrhage. In cyst, sometimes grumous brown organized hemorrhage can be seen within the kidney. So, when we do the dissection of a specimen submitted by urosurgeons to us, we will able to identify these are the cysts which are filled either with the hemorrhage or the old hemorrhage which is turbid or grumous in nature. There may be intervening normal renal parenchyma either in the disease or just fibrotic stroma seen in the later course. So, in any of the disease pattern, the chronicity prevail and that end in the collagenization of the stroma and it become fibrotic in nature. So, ADPKD manifest in fetus and infant. Also the cyst may involve in the glomeruli, so called as a glomerular cyst. So, at that given point of a time, these diseases do not make kidney dysfunctional, and since it is at the level of glomeruli, cysts are at the level of glomeruli, they cannot be detected by the conventional ultrasound methods. Okay. The liver is also demonstrating severely affected by hepatic failure in result. So, ADPKD is prone for berry aneurysm in the brain. Berry aneurysms are having a strong tendency to bleed with, and once they bleed, it is most of the time lethal for a given patient. So, this is something which is important for all of us to know. We can see the cysts are in the cortex as well as in the medullary area. They are of variable size, they are not uniform or radially arranged as we are seeing in the scenario of autosomal recessive. They can be seen anywhere or everywhere, okay. And that there is a bleed in the brain. So, here this is a glomeruli. So, what happened in the glomeruli? This complete area is cystically dilated, that is called as a glomerulocystic disease, autosomal dominant one. Okay. So, if we see what is the pattern, so Indian data is always small and missing. So, this is our own data where we are having the Charcot in this posterior urethral wall, omphalocele exostrophy with imperforate anus, spina bifida, urorectal septal malformation, autosomal recessive polycystic kidney disease. So, here this is a pattern, and a case of renal agenesis also we identified in our analysis. So, whenever we are opening Robbins, we are having a Western data, especially for such type of diseases or chapter which are covered. So, Indian data I am trying to communicate you. So, what is horseshoe kidney? So, once we are coming to the horseshoe kidney, this is a parent and the offspring. There are frequent intrauterine demises, 18 weeks, 3 month, missed abortion, like that, intrapartum death. So, like that these scenarios are there for these 3 ones. Non-consanguineous couple, that is a healthy. So, on ultrasound there is a single umbilical artery here, this is a proband. Absent left radius, short bowed right radius, bilateral bowing, short ulna, kidney report as normal. So, these are the bowing. Okay. This is a fetal X-ray, and then what we are able to see here is a kidney. So, karyotype is normal. What are the differential diagnoses? That is a TAR syndrome, Fanconi anemia, vectorial abnormality, and other syndromic radial ray defect. Fair enough. So, when that type of a scenario is there, we have to see whether it is autosomal dominant recessive. So, it is less than recessive, recurrence risk is 5 to 25%. So, the another common abnormality which we are able to see in the kidney in the phase of development is a horseshoe shaped kidney, and they are non-consanguineous, and they can be bilateral multiple cyst with the oligohydramnios. So, I am not discussing here horseshoe kidney, that is a different topic, but why I am touching here horseshoe kidney? Because sometimes these anomalies can have a combinatorial effect. So, this horseshoe kidney has a cystic renal disease also. Okay. So, here this is a abdominal wall opening and small phallus and absent of anal opening, dilated descending colon and sigmoid colon, because there is a imperforate anus. So, naturally the intestinal bowel will be having a dilatation and it is obscuring the other internal organs. So, this is a horseshoe kidney and urorectal fistula. So, colon ending is a blind pouch of a horseshoe kidney. So, this is a structure, this one is lying here and this one is here. So, this is like that. So, urorectal septal malformation sequence where horseshoe kidney developmental field defect is sporadic in nature, unknown etiology, and recurrence is very rare, but they can sometime have cystic kidneys. Okay. So, when they are having a cystic kidney, so that we cannot exclude in our understanding what type of a disease. So, it is not primarily the cystic disease, it is primarily the Charcot abnormality, that is the congenital abnormality of kidney and urinary tract in totality. So, renal agenesis versus aplasia or hypoplasia. So, that is a scenario when renal agenesis means somebody is opening the abdomen and you won't be able to identify the kidney, but that is not which is commonly done or seen. With unilateral agenesis on ultrasound, patient can have a normal life even. So, it is not something which you can always supposed to terminate, unless something like oligohydramnias or polyhydramnias, something which is manifesting in a bigger manner can be able to identify. So, no dysmorphism, anthropometry normal, small bowel, bilateral renal fossa, no obvious renal structure is identified on the ultrasound, bilateral ureter absent. So, then there is no other choice than the termination of that fetus, they have to terminate. And on the histopathology, right renal hypoplasia, left absent renal tissue. The cystic disease of renal medulla. There are two major type of medullary cystic kidney, medullary sponge kidney, nephrophthisis. Nephrophthisis is what? Nephrophthisis is a scenario which is associated with certain group of renal dysfunction which are classified as progressive renal disorder, which is having a variable number of cysts in the medulla, not cortex, usually concentrated at the corticomedullary junction. So, they are lying in the middle portion, where not exactly it is the cortex or not exactly is the defined medulla, but it is somewhere in the bordering area which is lying between the cortex and medulla. So, the cortical tubulointerstitial damage can be seen, eventually it leads to the renal insufficiency. Three variants: sporadic non-familial, familial juvenile nephrophthisis and renal retinal dysplasia. So, in such type of a disease, when we are doing the fetal autopsy, we have to really look toward the fetal eye also, whether it is normal or not normal. Okay. So, these are the medullary sponge kidney. This is a area of cortex, no cyst. This is a area of medulla, no cyst. Now, see the junction, there are cysts. Clear hai? So, these are the medullary sponge kidney. Gross papillary duct in the medulla are dilated, small cystic may be present. Cysts are lined by the cuboidal epithelium, occasionally by transitional epithelium. Unless there is a superimposition of pyelonephritis, cortical scarring is absent and pathogenesis is unknown. That is, आपको इसके लिए genetic testing करने की कोई ज़रूरत नहीं. So, before proceeding toward the costly genetic testing, we have to use the pathology filter. Whether we have to go for target mutation testing, whether it is a autosomal recessive or autosomal dominant, we can straight go for that. We know the gene and we can just have a genetic confirmation by doing the targeted mutation testing, or if we do not know, then we go for the making a library and try to detect it out. But certain situations where we can be able to identify, yes, it is medullary sponge kidney without much difficulty, genetic testing is not so warranted. So, genetic testing have a pathology filter that people are missing in their regular and normal learning. So, in summary, this is from your textbook of Robbins, where the renal cystic diseases are being mentioned: adult polycystic kidney disease, childhood polycystic kidney disease, medullary sponge kidney, familial juvenile nephrophthisis, multicystic renal dysplasia, acquired renal cyst and the simple cyst. So, these are the pattern of inheritance which is mentioned here, pathologic feature which are mentioned here, the clinical features and the complications are there, typical outcome and diagrammatic representation is there. So, we can be able to understand what we are able to see it here, that is in the today's class of understanding. Thank you very much for your patient hearing.